It is a tremendous honor to be here. When I did my homework and I reviewed the history of this institution, it resonates with what it means to care for human beings and to be a community, to kind of reconstruct what's been lost over the last century. And as my shelf space becomes more limited and I become more selective in who I want to connect with, truly is an honor to be here with all of you. So thank you for coming out tonight. And to the probably a little bit of disappointment that there's not 700 people here, I think there's an intimacy that can be gained when there's a small group and we can listen and learn from each other, and it allows us to interact at a much different level than big venues. And so I look forward to that. And this is interactive. I don't really have balloon animals or shadow puppets, but I encourage questions, comments, concerns, philosophical observations, to debate the merits of everything we're talking about. Without those things, this is just me speaking. This is not about me, this is about all of us. Okay? So what I hope to do tonight, share a little bit about myself, what I've done, some perspectives on where we're at with respect to healthcare, with respect to our society, some of the challenges we face, but really some of the opportunities we have to collectively come together and move the pendulum in a direction that is going to support life. We talk about palliative medicine, we talk about hospice. This is about living. This is not about dying. This is not a left of the aisle issue, it's not a right of the aisle issue, this is a human issue. And we needn't kid ourselves or be distracted by what's going on out here. This is what happens in here. It's a very human journey. It's a sacred journey. It's one that we will all face with absolute certainty. May come as a surprise to some of you. It's one that takes on a new meaning for me, as this is the second presentation I've given since my mother died about 5 weeks ago. And so I feel that there is her spirit comes down, catches me by surprise sometimes. But I think it makes me even more human and understand more clearly what this journey is. It can't be compartmentalized. That's the continuum. So that's kind of the goals for tonight. So I'm a goofy physician. I say I'm a goofy country doc. And what I try to do is take a little bit of clinical knowledge that I've garnished over the years and intersperse that with listening and hearing. My history is of practicing medicine for a number of years. I was very fortunate to be a director of a palliative medicine program as well as a hospice program. Most recently, prior to my new position, I was involved in a pilot project through Medicare and Medicaid. And it was 4 years in length, and we were able to really transcend the norm. We took palliative medicine to a place that it is not consistently taken. We saw several thousand people in a rural community across 8 counties in northwest Iowa. We were one of 32 facilities nationwide that was accepted into this program through Medicare, Medicaid Centers for Innovation. We started with the premise, or I guess I started with the premise, because again, I'm not real bright and I'm pretty lazy, all right, that I am just going to meet every patient right where they're at. And wherever they are and whatever they need, I'm going to try to make happen, period. The backing by Medicare, Medicaid was for statistics. There was no financial support. There was no increase in staff. It started out as myself and a nurse. The first week into practice, it was an inpatient consultation service. And Thursday of that week, realized we need to start a clinic because we can't just discharge these people, throw them over the wall, let them go and not know what happens. So we started a clinic the next week. Thursday of that week, I said, we got to go to their homes. So we started going to the homes and doing home visits. Thursday, there's something with Thursdays, because Thursday of the next week, I sat down with all the long-term care providers in the area, and I said, look, we've got to be integrated. We've got to have a seamless continuum of care. So we established clinics in each of those places and kind of walked the halls like a cop walking the beat. Got to know the people, developed relationships, empowered those who were caring for people to work to the top of their licensure and to, as some people have seen, go from this, practicing medicine, to actually caring for a person. And so within about 2 months, we had inpatient consultation service, full-time ambulatory clinic. I was going and changing urine soak sheets at home at 2 in the morning. I was on call 24/7. We were accessible every minute of every day. We were in bed in the emergency department, ICU, cancer clinic. Wherever it was, we had to meet people where they were. And it was about telling the truth. The first oath we take in medical school is the Hippocratic Oath. Don't ask me to say it in Latin. And the first line of that says, do no harm. So to a lot of us, it's I'm not going to do to you something that would hurt you. Well, if I don't share with you the truth, I'm essentially stealing from you the opportunity for you to choose how to live your life. I'm harming you. And medicine is so much about doing things to people without true informed consent, without transparency, without engagement beyond that acute episode of time. I quib it's incisional care. It's really directed at my orthopedic surgeon friends. Once you sew it up, you're done. They move on. So several years into the program, we had several thousand people we were caring for. The staff grew to just under 30. By the end of the program, which was scheduled to cease because it was a pilot project, and it did, we had seen, again, just under 4,000 people, the sickest of the sick. We had moved the continuum from that proverbial 12 to 15-month life expectancy, which most palliative programs around the country are, up to 96 plus months, first diagnosis, and integrated ourselves and made ourselves available not just to the patients and their families, but also the practitioners. So it was a collective reconstruction of community. So what were the results? And then I'm going to get to exactly how we define what true palliative care is, what its relationship to hospice is. And again, talk about some of the challenges that face medical practitioners from an educational standpoint, from a business model standpoint, from a societal model standpoint, and then end with opportunities for us to affect positive change. So at the end of our tenure in this program, again, the sickest of the sick, we had 95% of our people never had to go to the hospital. And these are what most people would term the frequent flyers. There was one beautiful woman that we cared for, and I'm going to call her Sharon. 2 years prior to our involvement, she had had a stroke. She was aspirating, which means stuff's going down the wrong pipe. She was getting pneumonia quite frequently. In the 2 years prior to our involvement, she had been hospitalized 18 times. She had seen the emergency department physicians many more than that. In her journey, a physician told her, you're aspirating, you have to have a feeding tube placed. Have to have a feeding tube placed. After that, there was a physician that said, you're aspirating, if you want to eat, you have to be on hospice. So the culture is not guiding, is not telling the truth, doesn't recognize the reality of these things. If you're aspirating, it doesn't matter what we do, you're still going to aspirate. Feeding tube, IV. I mean, certainly I would recommend don't eat my cooking. That's whether you're aspirating or not, okay? I don't put you on hospice. But what they stole from her was the opportunity to choose how she wants to live her life. Tonight, as we talk, we're going to talk about the patient care side of the coin, and that's where all of this really starts. That's the genesis of success and change, and that's the power. But I would be negligent if I didn't flip that over and say there's an economic side, and there's a very harsh reality that we all need to be aware of glacier proportions. So the 2 years prior to our involvement, and you can calculate this, you can go on the website, Dartmouth Atlas, and do this yourselves. She had just under $1 million in healthcare expenditures. I want you to just realize, I don't care about the money, okay? And we never did in this program. We put the patient first, but let's just compare apples to apples. 4 years of our involvement. I saw her, I sat down with her. I said, Sharon, and she's competent. I said, I've read your history. Here's what's going on right now. This is your 10,000th aspiration pneumonia in the last few years. Tell me who you are. Tell me how we got here. Take me back 6 months, 6 years. So I just listened. I said, okay. So what's important to you? I said, my family. I said, what do you want to do? He said, I like to eat. I go, me too. What do you like to eat? I like hot dogs. Not so much. Okay? I said, well, why don't we figure out a way that you can eat hot dogs? No, they won't let me. I go, who won't let you? Well, the doctors. Why? Because I aspirate. You're aspirating on the stuff they're putting in your feeding tube. I go, it doesn't matter. Wouldn't you rather, if you're going to aspirate on a hot dog? Yeah. So what did we do? We went to the care facility. We had the family come. We sat down. We had this discussion again. She knew exactly what was going on. She knew that at some point in her life, she would more than likely die from an aspiration pneumonia that got out of control. But again, the hot dog's a lot better than whatever we're mixing and putting in her belly. And she has the right, legal right, ethical right, moral right to make that decision herself. Not me as a goofy physician. Not a care facility. And so we had the discussion, explained risk versus benefit to everyone, documented everything. We said, all right, now we know what your goals are. Let's support that in a clinical manner. What's the first, second, and third things we're going to do when you aspirate again? Because absolutely, you will aspirate again. And so we said we can hang IV antibiotics. We can have our team here 24/7. If you spike a fever, if you start to get short of breath, all these things that fall into the goofy clinical perspective of the practice of medicine, let's bring to the table. So fast forward, 4 years in the program, she was hospitalized 3 times. 1 time for gallbladder. I can't do anything about that. Okay, you don't want me to clip your fingernails, let alone do surgery on you. Okay, 2 hospitalizations. A couple trips to the emergency department. Overall spend less than $30,000 because she came in, got antibiotics, and was brought back to the care facility within 48 hours because it was seamless. We were going to be there. We could check on her. But that patient side of the perspective, was she happy? Oh yeah. Did she eat hot dogs every day? Absolutely. Guess what the only channel on television she watched was? Cooking Channel. And so Sharon's quality of life was enhanced tremendously. But the ripple effect is the people that were right there by her side caring for her, they were fulfilled. They got to do what they want to do. They got to do their jobs. They got to care for her. They had the support and encouragement to take those steps, whereas previously, spikes of fever, sounds a little rattly, send her to the emergency department. So there's all these tangential effects of decreased turnover in a long-term care facility, and it kind of spread like wildfire. People are like, wow, I want that kind of care. This guy does some amazing balloon animals. I want to see those. So we had a 95% zero hospitalization rate. We had the highest patient satisfaction rate out of our entire system, and I worked for the second largest non-denominational hospital system in the country, just under $5 billion annually. And I don't just mean our facility, but we were by far greater than anyone else. So the myth that these conversations steal hope or my patient's not ready for it, absolutely incorrect. People yearn for the truth. People yearn for authenticity, transparency, hope, options. In addition to patient satisfaction, we had the highest likelihood to refer to others, which is something I found much, much more gratifying. Because if I'm getting poked in the eye by you, I'm not going to say, hey, you should go hang out with this guy. Because it's just not fun. It's not what I need. It's not what I want. But if there's something that nourishes your soul, nourishes your being, and people are actually connecting with it, they're going to share it with others. When you look at a hospital system, and this will segue into what is true palliative care, their perspective on care, for the most part, is much different than ours. As seen when the pilot project ended, the CEO of our organization said, "We've checked the box. Thank you for your work." And it came to an abrupt end. So it's not about you, it's not about me, it's not about the goofy physician. There's a lot of economics involved. But some of the things they look at are 30-day readmissions. So you're admitted to the hospital, you get discharged, and for whatever reason you come back in 30 days, there are some regulatory issues with the hospital system. We started out about 40%, and with our program we got down to 3% by the end. Okay. And I wasn't standing out there saying you can't come to the hospital. I'm going to be very, very clear. I was neither limiting care, limiting choice. If you wanted to go to the hospital, consistent with your goals, you wanted to be on a ventilator, consistent with your goals, absolutely. Is that a palliative care success? Absolutely. Palliative care is not driven by prevention, it's driven by empowerment. So by putting the patient first and then looking back at all the things we did, we had patient satisfaction, decreased length of stay, all these things, and we bent the cost curve, like coming to your house, by 70%, 70. And I don't know if that's a sign, but I told you my mom is here tonight, okay? So what is palliative medicine? Here's how I explain it to patients. Hi, I'm Tim, just a country doc, and I work with a program that helps put all the pieces of the puzzle together. We're dealing with people who have big ticket items, okay? And so my role is to make sense out of all these moving parts. But first let's just stop and say, okay, how are you feeling today? Okay. You've been admitted to the hospital for pneumonia. You breathing okay? Okay, what's going on? Here's our family, introductions. So, okay, again, tell me who you are. How did we get here? Tell me how the last months, years have been. And then sitting down and saying, okay, you have pulmonary fibrosis. Do you understand what that means? 99.9% of people, I have no idea. Okay, so let's talk about it. Let's empower you to know what this is. Let's empower you to know what the realistic journey based on my clinical experience is. Let's take a hard stop. Let's say, what's sacred to you? If you have 1 hour to live, and I've had those consultations, or if you have a brand new diagnosis of something that could be beat, the conversation is the same. Death is this line in the sand, again, that is inevitable for all of us. As a physician, I can't change it. I got some bells and whistles that may fudge it a little bit, but not significantly. So I honor it. Palliative medicine is a conversation about this journey. How do we get there? How do we take it 1 year, 1 month, 1 week, 1 day at a time? And how do we integrate all the bells and whistles of medicine, all the bells and whistles of our family, of society, and integrate it into your journey and make it the best journey and try to give you the pencil, the pen to write those chapters of your lives. At a very fundamental level, I offer palliative medicine is a coming together of people so that we can stare into the abyss of the unknown, which really is life, with cancer or without, and get through it together. Every patient I've ever seen, I ask, are you afraid? And 99% of them say, I'm not afraid of dying. Interesting, because it's not the question I asked. I say, what are you afraid of? I'm afraid of getting dead. I'm afraid of the unknown. What is this space? A fundamental tenet I would offer of human beings is fear of the unknown. My son turns 10 next week, and he was afraid of the closet monster. Not because I hid in his closet when he was young and jumped out and scared him. I did not do that. So what did we do? In the middle of the night, Dad, Mom, we come in, we turn on the light. We offer that reassurance. It's a micro community, but it's a community. We overcome that fear of the unknown. And so then he can sleep through the night. He can live his life not worrying about closet monster. My daughter, when she was 4, wanted to learn how to ride a bike without training wheels. My first career about 30 years ago, I was a professional bicycle racer. I said, honey, that's just a bad move. It's never going to go anywhere for you. But as parents, we know if you're going to learn to ride a bike, you're going to fall down and skin your knee. And I know that. Am I going to say, no, you're not going to ride a bike? So I'm going to prevent her from living her life. So what do? Say, honey, fantastic, I'm here for you. You know, we always wear a helmet. Okay, you can go without the suit of armor this time, all right? But it's a tough thing, and this is a challenge, but I'm going to be here for you. And you may fall down. You will fall down. But we're going to pick ourselves up, dust ourselves off, and start all over again. And so to the patient who has congestive heart failure, do I know they're going to have a heart failure exacerbation and be short of breath? Absolutely. Can I predict when that's going to happen? Yeah, not a clue. So what do? We create a community that says, this is what's going to happen, and here's how we're going to support it. Here's my cell phone number. Every patient I've ever had has my cell phone number. And it's written in a few bus station bathrooms too. But it's empowering you to know that, okay, this is your disease. We're going to focus on life. There's going to be a skinned knee, but here's what we're going to do. You're going to call me. Here's the things, the second thing, third thing, fourth thing. And so people lose that fear of the unknown, and they're able to live and love and laugh and learn and grow, metastatic cancer or not. I shared this story. I had the fabulous privilege of chatting with some medical students at the University of Tennessee yesterday, who subsequently, I think, have all dropped out of med school. It was a gal in her 7th or 8th decade of life with a new diagnosis of widely metastatic lung cancer. And I'll just be very frank, she was dead. And I don't mean that in a not a heartfelt way, but it's just very pragmatic. She knew that her life expectancy was markedly limited. And when we engaged and I asked her the questions, she said, again, I'm not afraid of dying, I'm scared of this space. And I said, what's your little voice tell you? The greatest diagnostic tool ever is listening to that little voice. She said, I think I probably have maybe a couple of months. I said, I think you're probably right. And, you know, unless something sneaks up on us and surprises us, it seems very reasonable. And so when I say she was dead, I mean, we're all dead. It's not being callous, it's not being mean, it's just being, look, this is your life. Yeah, I think you're absolutely right. A couple weeks after meeting her, we were doing some symptom management. So a big thing in palliative medicine is symptomatology, is dealing with the physical body. So she had some shortness of breath, she had lung cancer, tough to breathe. How do we make her more comfortable? So symptomatology is shortness of breath, it's pain, nausea, anything that has to do with that physical part of the body. Palliative medicine is also the 50% of the body that is existential. It's spiritual, it's social, it's emotional. And if we don't nurture both halves, the body, the human being can't be one. And if we're not one, we're just static. Cancer or no cancer. As a whole, we can move forward on our journeys. And so, this beautiful octogenarian called me. It was about 2:30 in the morning. And I said, are you okay? She said, are you having pain? No. Trouble breathing? No. Is your husband there? I could tell she held out the phone because I heard somebody snoring. She said, I didn't want to wake him up. She said, it's just that I'm scared and I'm lonely. 2:30 in the morning, it's when the silence is most deafening and our fears manifest the greatest. And I said, what can I do for you? And she said, just talk with me. I said, absolutely. I'm good at talking and listening. And so we chatted for a few minutes. She said, I have a favor to ask. I said, sure. She said, would you read me a story? I said, you have Curious George or Dr. Seuss? I got little kids. And I offer, as I did yesterday, to this class of medical students, that was the greatest clinical experience I've ever had. And what did I do? It had nothing to do with medicine. It was acknowledging and honoring the space of this human being on her journey and saying, I'm here. I can't change what's happening. Subtextually, I can't fix that you have metastatic cancer. I can't fix that you were going to die in a few weeks. And she did, about 4 or 5 weeks later. But I can acknowledge the humanness of this journey and be present. And that has more power than anything clinically we can offer to anyone at any point in their journey. So palliative medicine is about meeting people where they're at and looking at both halves of the human being and bringing it together so we can move forward. So it's symptomatology, it's integration of actual high-level medicine, understanding pathology, understanding options, but more than that, understanding human beings and working with those individuals, as well as all their other physicians who may be involved. Again, we're talking palliative medicine is something that can be employed concurrently with active therapies, aggressive chemotherapies, surgeries. I've made the call to the cardiologist on several times that I think this person could benefit from a thorough evaluation and I think they may need a heart cath. So it's not precluding things, but looking at all the options and aligning them with what's sacred to someone. Does that make sense? And so what is its relationship to hospice? It's a question I'm asked quite a bit. And it's really at the forefront of a lot of the strategic things that are going on in palliative care right now. palliative medicine is in its pre-adolescence as a specialty. We were accredited about 10 years ago, and I think we're just kind of learning to walk. And so there's been a lot of shingles hung up all over the country as palliative medicine. It's the hip thing to do. A lot of people are doing it for the wrong reasons. A lot of people aren't particularly trained, and a lot of people have a very limited scope of what it is, can, and should be. Okay? I would offer about 99% of the programs around the country are, we're going to come have the talk and get you out of the hospital and take you to hospice so you can die there instead of in the hospital. Because the hospital doesn't want you there. Because they have a financial penalty if you die on their floors or in their beds. Okay? And so if we're talking true palliative medicine, upstream, integrated, it is inexorably tied with hospice in that everything hospice is palliative, okay? But not everything palliative is hospice. So you think of a big umbrella, and way down over here, an option of care is hospice. And it's a philosophy that was born from Dame Cicely Saunders many decades ago in the UK. We can still deliver that type of care and not call it hospice. Hospice has taken on an insurance benefit meaning in this country through Medicare. So it's somewhat bastardized, if you will. It's when a physician deems that you have a life expectancy of 6 months or less. Okay. But with or without that, you can engage in hospice philosophy of care, which again is different than palliative. Hospice is, we've come to this point where we're not going to actively seek aggressive treatment for whatever ails you. Are we still going to focus on quality and comfort? You get a pneumonia, is there an option to treat you? Absolutely. So in this country, hospice is at some level defined by the Medicare insurance benefit. Palliative medicine upstream moves seamlessly into that for people who choose that as their option of care. And when I talk to people, I say, look, I have at my disposal certain resources. And whether you call it hospice or palliative care, if you don't like the word hospice, I would ask, what's your favorite dessert? It's called ice cream, okay? What happens when you eat ice cream? I feel good. It nourishes me. It makes me happy. That's what this level of care is. And so when we transition to that point, my job is not to sell you on palliative or hospice. My job is to care for you, to bring you as much ice cream as you want. And if that's under a hospice banner, okay. And so to take away the fear of the unknown, the fear of what that word may be, is a palliative goal. Again, everything hospice is palliative. I'm a palliative and hospice physician, okay? It's not one against the other. It's all about caring for human beings. So that's the relationship with palliative care and hospice. One of our goals this year at a national level through the Center to Advance Palliative Care is to truly define clearly what true palliative medicine is, how you get credentialed in it, and then tie it to policy. So it'll be more delineated and less ambiguous for a lot of physicians and people. So what are some of the tenets that preclude the practice of palliative medicine? I think there's three that I'd like to touch on tonight. One is society, one is medical education, and one is the business model of healthcare. From a societal perspective, with the exclusion of all you wonderful, intelligent, very self-actualized individuals, we don't talk about life. We don't talk about death. Death not being the opposite of, but the culmination of living a life. And so unless I'm on the cover of GQ or Vogue magazine, I've done something wrong. I'll tell you right now, I'm never going to be on the cover of either. And as we age, we're put in this box of having failed or not being of value to society. And so we don't ascribe to talking about the reality that all of us are going to face, and then it hits us like a brick, whether it's our mothers, our grandfathers, or ourselves. Inevitably, something's going to happen to all of us. That's going to be something that makes us turn the corner. And if we're blind to that, it makes it that much more difficult to deal with. I've done a lot of work in Tanzania, and it's very remote, rural areas of the country where I can't even get a Tylenol. I guarantee you they don't want to die any sooner than we do. But they're in a society, because of economic limitations, it is something that they're very familiar with, and it's not an every night at the dinner table conversation, but they're very fluent in this is where it's going. And so let's accept the reality. And what I've learned is they're able to live and love and learn and grow and laugh through their last breath. And it's less scary because they've humanized the experience, which is what we used to do 100 years ago. We were having this conversation just earlier tonight. So my mother died in her home. As a son, not a goofy physician, but as a son, my wife and I, we brought our kids, my brother brought his family, and it was a human experience. 3 weeks of caring for her and celebrating and grieving. And it wasn't dehumanized by saying this is a clinical diagnosis of dementia and end-stage lung disease. She was a person. And that's what happens in Tanzania, and that's what's happened 100 years ago here. 90+% of people died in homes a year, 100 years ago, and now 85 to 87% of people die in hospitals. After having gone through this revolving door time and time and time again. So the last 2 years of my mother's life, she was hospitalized once. And it was because we had these conversations, and while she was still lucid, we set up a network of caregivers, and we set up this pathway of, okay, here's what she wants, and we're going to try to make it happen. So from a societal standpoint, we shun talking about the reality of life, and I think that precludes us from enjoying a lot of life, and we have some misperceptions when we come into the hospital, and as physicians, a lot of times death is optional. We don't talk about it. We don't tell you the truth, not out of malice, but we don't see it. We're not trained to see it. We're trained to fight infections and cancer and pathology, not to recognize the human journey. And so if your kidneys fail, we'll just start dialysis. Your heart quits, we'll put an LVAD in. Well, to what end? And to what means? And do you really know what that is? And do you really have the option and choice? Dear friend of ours from Des Moines, again, forgive me, you heard this yesterday. Early 40s, diagnosed with breast cancer. 2 kids are friends with our kids. A couple years ago, she calls and she says, I don't really understand what you do, Tim, but could you come over and just kind of talk about, just help us make sense out of what's going on? Absolutely. So my wife and kids come over. Her parents are there, his parents are there. She said, I've been diagnosed with breast cancer. Here's my 18-month calendar. So I just came back from the cancer doctor, the oncologist, a couple of days ago, and he said, okay, here's what we're going to do. We're going to do a bilateral mastectomy. We're going to do a total hysterectomy because I have a genetic marker that predisposes me to cervical cancer later. Here's all the chemotherapy we're going to do. Here's the radiation we're going to do. And she says, I don't even know what cancer is. I said, okay, well, let's start there. Here's kind of generally what cancer is in layman's terms. Here's what breast cancer is. Here's what your breast cancer is. And there's this pause and this gasp, and she says, I could die from this. I said, yes, you could. 1 in 7 women are diagnosed with breast cancer in this country. I said, I don't say you could die from this to be mean or scary, but that's the truth. She said, I didn't know that. I said, but let's go back to all these things that can be done to try to prevent that. I said, what is sacred to you? It's family, my kids. I said, are you scared? She goes, I am now. And again, she said, I'm not scared of dying. I'm scared of this journey, and I'm scared of leaving behind and what I would miss. I asked her husband, are you scared? And he just stared at me. And he said, yeah. I said, so you have options. She goes, I didn't know I had a choice. And so we went through each thing, and we talked about chemotherapy, and this is what that does, and this is what you may experience, but here's how, we might be able to help. So through her journey, as she was nauseous, go over, give her some IV fluids. Again, really recommended she not eat anything I cook, and walk this journey one day at a time with her. And so there was all the chemicals and the medicines. And I said, okay, let's stop and let's talk about the surgical procedures. Let's talk about the bilateral mastectomy and the hysterectomy. So let's focus on the emotional, the spiritual, the existential person. Some people experience a loss of self, a loss of identity. You can experience a loss of your sexuality. I don't mean intercourse, but these are physical traits that are associated with being a woman, a mother, a sexual being. And we should talk about these things because it's not insignificant. And so we explored that. And we talked with her husband as well. How do you have that communication when you're feeling one way, you're not sure how she's feeling? How do we manage expectations through this whole journey? Not just dealing with pain and nausea, but perception of self and how the journey of our lives changes all of a sudden and very abruptly with a diagnosis of cancer. So fast forward 18 months later, clean as a whistle, has reconstructive surgery, invites all her friends over, girlfriends over for a showing off party. I wasn't invited. And she's doing very, very, very well. And so that's a real life example of true palliative care. We talked earlier about all these hospital avoidances and the cost reductions. The other end of the spectrum, Andy Billings, a physician who passed away a couple years ago, a formative thinker in this space. He started the program at Harvard with his wife, Dr. Susan Block. And Andy was quite a character, very soft-spoken, gentle, witty. He died after 2 bone marrow transplants, and he died in the intensive care unit, on a ventilator. Was that a palliative care success? Absolutely. Because he was informed, he was empowered, he made the choice to choose that path. And so it's just really hitting home that this is not about taking away, and it's not about withholding or withdrawing or discontinuing care. It's about the human being. I kind of think Andy did it, at some level just to spite the medical community and say, yeah, gotcha. So we have a medical community that does not understand the human journey, and it starts with medical education, which this is a relatively new aha phenomenon to me. I think it is a self-fulfilling prophecy of failure, medical education, after you move beyond basic physiology and anatomy, when you start to talk about pathology. And I offer this is a platform that is antithetical to actually caring for human beings who come to this space, this turning of a corner, the 15% sickest of the sick. So in all of our education, we are taught to fight pathology, fight disease, fight infection. It's kind of the general mantra, to understand its origin and all the options we have to take care of it. At a certain point, every one of us is going to turn a corner. And our body is going to be declining at a much more significant rate than previously. If you throw cancer in there and you're clipping along and then you turn that corner and the body is dying, what do most physicians do? We fight it harder. Let's try this chemotherapy. Let's try that chemotherapy. Let's add a little of this, a little of that. What we know with absolute certainty is that just potentiates the negative decline. Most people die sooner and with less quality. The more you die, the more we do to you. It's a self-fulfilling prophecy of failure. So we don't recognize that true palliative medicine, at least the perspective of understanding the journey, we did an awful lot less to people, and they lived better, and statistically they lived longer. You look at a seminal article out of the New England Journal from 2010, metastatic lung cancer patients with true palliative medicine, metastatic lung cancer patients without. So those that had palliative medicine had less depression, less side effects, needed less chemotherapy to keep their tumor sizes equal to those of their non-palliative care colleagues, and they lived 3 months longer. So I said this every time I talk, if palliative medicine was a medication, every physician, every cancer doctor, no matter how much it costs, would write a script for it. So we have a medical education system that sets us up for failure at some level. And then you come into the business model, which presently is a fee-for-service model. If I do unto you, I am guaranteed reimbursement. Regardless of what the size of that reimbursement is, I'm guaranteed reimbursement. So if I am an interventional cardiologist, and I have dear friends who are cancer doctors, I have dear friends who are heart doctors, so I'm not picking on anybody. And if that's my parole officer, I'm not here, okay? So if I am guaranteed reimbursement for doing a procedure to you, why would I not have 10 partners and do 100 procedures a day? And if there's no regulation as far as, am I any good? What are the outcomes? Do you really need it? Were you offered choice? Man, that's a gold mine. And I'm not saying physicians practice this way just to make the money, but it's a system that's set up that potentiates having things done to people. And if I roll into the emergency department tonight and have chest pain, I certainly hope I've got a cardiologist who says, all right, let's check you out. And if you need a cath, yeah, I want them to give me a cath. Absolutely. I celebrate their knowledge, expertise, and experience. But we have to know when to say when, and we have to know how to ask the question. 80-some-year-old woman who had recurrent breast cancer had metastasized to her brain. I was caring for her at home. No matter how much I told her it was ice cream, she didn't want to be on hospice. I said, that's fine, okay? Your goals are to be at home, to be comfortable. I can do that. You know, I don't have as many resources as I would if I was working with a hospice team, but I can do that. So I was caring for her for a couple months. She was declining. She said, I think I probably have a couple weeks left. Her son came, I think it was from Alabama. I know that's probably a curse word in the state of Tennessee. To stay with her for a while. And one night she started experiencing horrific shortness of breath. Or maybe not. I'm agnostic. It doesn't matter to me what team you want. And so what does he do? He's human. He calls 911. Was that wrong? No. She comes to the emergency department. So here's where the system breaks down. What's going on? Can't breathe. Having some chest pain. Okay. Let's get some labs called cardiology. They looked at a very minute portion of this woman. What's staring them in the face is widely metastatic cancer, and she's actively dying. Who comes in? Cardiologist. And this happened to be someone who's so far on the other end of the spectrum. You know, my nickname was the euthanizer in public by this provider. And he comes in and he says, okay, it looks like your chemicals of your heart muscle are a little elevated. You have a history, 40 years ago of heart things. Do you want to die? It's the wrong question. She was dying. Okay, if you don't want to die, I need to take you to the cath lab right now. Takes her to the cath lab. Nothing wrong with her heart. She was throwing blood clots from the cancer to her lungs, making it hard to breathe, giving her some chest pain. I come in, so this was Sunday, late at night, early Monday morning. I come in Monday morning. I see she's on my rounding list and she's in the ICU, and I say, okay, let's figure out what's going on. I call the gentleman, and this will set up where I think a true opportunity for us is. Call the cardiologist and I say, please help me understand what's going on, trying to piece this together. Click. Okay. So I made sure he wasn't involved in a procedure. He wasn't in a consultation. This is somebody I've known fairly well for many months. How can I help? Click. Okay. So I met him on the playground after school. No. I wanted to. So he comes storming down to the ICU, and she is at the point where she's in respiratory failure, which means she's either going to die, or you put a tube down her throat and hook her to a machine to breathe for her, which she does not want. She said, whatever it takes, get me home and let me die at home. She knows what's going on. I share this with the gentleman. I say, look, her goals are, she can't be a do not resuscitate. She gave up that right when she allowed me to do the heart cath. I go, no. She may have suspended that during the procedure, but she is lucid. She has the legal right to change her mind. It will go on my 30-day mortality list. She told me she didn't want to die. I said, she is dying, and maybe that was the wrong question to ask. Well, you just euthanize people. I said, well, this isn't about you, and it's not about me. It's about her right now. And she wants to go home. And you know, as I do, that she has the right to go home. So, begrudgingly, he accepted her wishes, and we got her home, and she died the next day with family surrounding her. But it sets up, again, we're not taught to see the human being. We're not taught options. We're not taught to listen or hear. We're certainly not taught to care. From a system perspective, when I went to administration and said, I'm a little frustrated because of this encounter, recognizing all these other things we've just talked about, they said, well, okay, thank you. Again, it's predicated on if I do unto you, I'll get paid for it. So again, it's another platform. There's medical education, and now you have the business model of medicine that is a platform that is antithetical to providing good, honest, true, informed, authentic care. And then we also talked about the societal model. There's a lot of things against caring for me, caring for you. I sat on the board of this institution for several years, and never once did I hear the word patient. And their motto is, the point of unity is you. To me, the point of unity is your wallet. So what can we do about it? Part of my job is to inspire all of you to say, hey, we need to change. Not just because the economic reality is right now this 15% of the population is 85% of the healthcare spend, just under $4 trillion, which is about 18% of the gross domestic product of the United States of America. And if you follow the slope of the line, as far as how many people are going to join this sandbox over the next 2 decades, you're looking at 65 to 70% of the gross domestic product of the United States of America for this population 20 years from now, and I argue there's no value in that. We're spending a lot of money and people are not living longer or better. We spend 10 times more on healthcare than the next country in the world. We're ranked 37th or 38th. And we have a higher mortality rate than some non-industrialized countries. So the opportunity is to know the facts and to advocate for yourselves, to take this human experience that all of us have walked and say, that's what I want for myself, for my mom, for my dad, for my grandparents. Not only are you, yes, human beings and patients, you're also the customers. It's your right. And if we have proof that you can live better based on what's sacred to you, and you can live a little longer, absolutely. Demand choice. Demand that opportunity. This is not a conversation about healthcare reform, but rather how we reform caring for human beings. So while I wanted to go toe-to-toe with this interventional cardiologist, probably could have taken him. What we have to do as a collective is be a more resounding dialect. My job as a palliative physician is to come up with the language, the meter, the verse, the rhyme, the definition of really what this is so that we can have accreditation and policy and all these things that go with it. But what we can do here, take off my goofy doctor hat as a son, is say, I'm going to advocate for what's right and advocate for what I know my mom has emphatically said she wanted. And that's to be treated with respect and dignity as a human being every breath of her life. Many years ago in the country of India, there's a gentleman named Mahatma Gandhi, and he had this social awareness that colonialization probably was not the right thing. And he was asked by some high-level English administrators, is it your desire and belief that England will just peacefully leave India? And he said, yeah, that's my goal. How did he do that? Because he was right. Did he do it by going toe-to-toe with the cardiologist? Toe-to-toe with the English imperialists? I offer history would be much different if he did. He wasn't against the English, per se. He was against what they represented and what they did to himself and his country. So he stood side by side millions and millions of fellow country persons and demanded change, demanded choice, integrity, respect. He changed the world. That's my charge to all of you. Stand side by side. I can scream and yell, and I have. Different physicians, administrators, it goes nowhere. When you're going toe-to-toe, both people lose. Again, this is not against the cardiologist, it's not against the system, it's not against medical education. We need all of these things. But we need to advocate for a shift in mentality. And we need to honor patients, families, caregivers. And we can do it. There's a lot of little ground fires all over the country, and the opportunity is to make it much bigger inferno and demand change. So palliative medicine is about living, it's about choice, learning, growing, loving. Every moment of everyone's life, it is available. We need to demand it. Not just in the hospital, wherever we're at. It is that different voice in healthcare so that patients can find their own. Thank you very much. Questions, comments, concerns, philosophical observations, disagreements, favorite flavor of ice cream?
You seem like you only talk to patients, but you have to deal with families. And that's a different ball of wax.
Can you repeat the question?
So I talk with patients, but talking with families is a different ball of wax. Talking with my family is a different ball of wax. I'm going to elicit our psychologist friends' help over Thanksgiving next month. We do. We have the luxury of time, and whether it's 30 minutes or 3 hours, whether it's one family member, I've had 6 cell phones. I'm not technologically advanced, on conference call for 20 or 30 people from all over the country. And really, it goes back to this fundamental tenet of what is your fear, and managing expectations. Because even some of the most obstinate family members, a son who comes in estranged from 20 years and is seeking atonement and says, we got to do everything to mom. Okay, it's understanding that people are afraid. And listening, just listening and going, I get it. It's scary and it stinks. This hurts. Tell me about your mom. 99.9% of everybody I've ever cared for, right, and their families, when you allow the humanness to come out and allow them to listen and hear what whoever their loved one is, what that voice is saying, they're like, yeah, why would we do all this stuff to her? And again, I'm not about not doing things, okay? I think that conversation and that potential conflict occurs later downstream, the closer you approach the end of life, than the new diagnosis. With the new diagnosis, it's like I did with my friend. Let's talk about what this is so we understand it and what all the options are so we can fight this thing. And we always fight. Even when we can't cure, we can define what are we fighting for. And that's empowering as well. And one of the things that I just cringe and I hear all the time from other physicians is, well, there's nothing else we can do for you. Oh, yes, there is. I can't beat your cancer, but I can care for you. I can be there for you. You can call me and I'll read you a Curious George story. We always have something we can do for other human beings. And so to reestablish this true sense of community, right? It's not just me. I sit at a round table with social work, nurse practitioners, nurses, clergy, occupational therapy, respiratory therapy, acupuncture, laughter therapy, pet therapy, whatever is going to be consistent with your journey. It's a round table and everybody has an equal voice. I know this much. And I know what I don't know. And most of the times I know the difference between the two, okay? So the real sense of community that is in this microcosm of care team extends to the long-term care facility. It extends to the neighbors who are going to come by and check on my mom, as they did so many times, and my dad, who was a primary caregiver who had a stroke. And it's even the custodial person, true story, who at 3 a.m. is cleaning and heard Mrs. Smith crying and went in and just sat and listened and said, Doc, I got to tell you what Mrs. Smith wanted to share, but just couldn't with so many people in the room yesterday. So it's putting that puzzle together. And also who sits at the table of the family and the other physicians.
I saw a gentleman, a 68-year-old gentleman, in consultation in the hospital today for goals of care.
Let's see if this works.
I want to make sure you hear this. I'm a palliative doc, And today I saw a consultation in one of our hospitals, a 68-year-old man who had heart disease, stage 4 heart disease, pretty bad. And the consult was goals of care. What does he want? And I covered the usual things. I found out that in fact he did want full treatment. He didn't want to limit what they did to him. And he also wanted resuscitation, even though the prospects weren't so hot for getting through it. And my first thought was, well, my job is done. I have to find that he's not a hospice candidate because he wants full treatment, and that he's not a candidate for DNR because he wants resuscitation. What this gentleman has helped me realize tonight is that my job was just beginning.
This was not staged. Thank you very much for that. It's a lesson that took me a while too. I was very fortunate. I had a gentleman who was probably the goofiest, most uncoordinated white guy I've ever met. He was a Zen Buddhist, 6th degree black belt. He was my mentor out of Stanford. You know, and come charging in, expletives rolling off my mouth, oncologist this, cardiologist that. And he'd say, what is. And then we figured out the follow-up is, but what is? You know? And so, thank you for that.
Well, I'm listening, but I am a caregiver. And I think that he said this patient was 68 years old. And I personally feel that the younger they are, the more they clean, no matter what they say. The doctors say stage 4 cancer, stage 4, whatever. They gonna still go for, let's do all we can do. Because they think they haven't lived to their full potential yet. They think they've been cut short of life. So I think the younger they are, the more they'll go for, let's do it all. If you get somebody 90, they ready to go.
Sometimes you're right. And I think that is a very accurate statement. You know, not to burden you with personal thing, I've got a cousin right now who's 53 in an intensive care unit dying of stage 4 breast cancer. She's got a 30-year history of alcoholism. You know, so it puts her behind the 8 ball. And it is, let's do. So I think it's our duty as, again, these goofy physicians to honor that. You know, once we've come clean and said, look, you have stage 4 cancer, if your heart stops, it's a zero-sum game. Game's not the right word, but there's 0% chance that we're going to successfully resuscitate you. But I'm okay with the ambiguity of you being a full code, you know, not wanting us to forego CPR, if that's going to help you live the time you have. Okay. My job is not to convince you this is the path to take, but to be there for you as you make decisions and to support you. Every person I've cared for, and I've done pediatrics as well, okay? From premature babies to 18-year-olds with cystic fibrosis and everyone in between, and 20-year-olds and 30-year-olds and 40-year-olds, you know, and I had a 105-year-old I cared for, so the whole spectrum. What most people are not given is the opportunity to take a deep breath and listen to that little voice in their hearts. And I say this, I am not a particularly religious man, but I know with absolute certainty that voice is holy and sacred and guides this time of our lives more so than anything we could ever order. And so we need to come with that perspective of listening and hearing, honoring, accepting, and people find their own path. And if, like Andy Billings, someone chooses to escalate care and they die on a ventilator, my role is not to say that was right, wrong, or indifferent, other than we empowered them with the opportunity to choose. So, sir.
I like all of what I'm hearing. I'm wondering something about this, how, you know, with all the citizens for doing procedures, how does a palliative doctor get paid?
I work on tips. No, thank you for that. Somebody always asks that question. So, and I do a lot of policy work. So I had lunch a couple weeks ago with CMS, Director of Innovations, and that's a huge nut to crack, right? It is still a fee-for-service model, and as a physician, I draw a salary, and I'm able to charge Medicare for my services. It's not as much as a cardiologist, for just an office visit, right? So I will be reimbursed predicated on the amount of work I do. Where that ends, for the most part, is once you leave the hospital. There's a lot of nuanced things, and there's a lot of shifting and stuff going on right now as far as how do we get this type of care paid for outside the hospital, all right? Most organizations, these monolithic hospital structures, have opted not to support this type of care because not only is it expensive, but I make my salary back in a year, but you're not going to make any money off me. And in fact, you're going to lose money from a system perspective. 70% per capita reduction is scary, and it's not sustainable. But when you juxtaposed it to 70% of the GDP, this is about healthcare. So what is happening at a very high level from a policy perspective, probably more than you wanted to hear, is how do we put some teeth into some actual regulatory compliance mechanisms that make sure the cardiologist is qualified, is doing a procedure for the right reason, is giving you informed consent, and has good outcomes. And not that we're going to take away if somebody dies, because that's what happens. It's the natural phenomenon of being a human being in a biologic organism. But we have no checks and balances right now. I was scheduled to have lunch with the chairman of the Ways and Means Committee first part of September, and postponed until some indefinite time because of the journey with my mother. There are some very bright people on both sides of the aisle who understand the economics and are having conversations not just with Medicare, Medicaid, but the Kaiser Permanentes, Blue Cross Blue Shields, and saying, we got to fix this. The pendulum is going to swing the most, I would offer, with the payers. So you have your patients, you have your hospital systems, and you have your payers. My 70% cost avoidance to them is profit, right? And don't forget, we're talking better patient care, people living better and longer. But they get, wow, if I don't have to shell out 70%, that's fantastic. That's not how hospitals think. They don't look at cost avoidance as long-term viability and financial well-being. They just look at it, our bottom line drops this quarter. So I think the next 10 years are going to be very, very interesting. This is taking on a new perspective as there's more data that proves the old system doesn't work for this population. So, but I still take tips. Now, Sherry, I talked about the 105-year-old. That's about 10 years ago. She came in, and she was in heart failure. She'd never been to the hospital before. Had 8 kids, all delivered at home, 5 generations in the room. So right on and lucid. It was amazing, and no filter, and quite a flirt. And so I'm chatting with her, and we'll just say her name is Alice. I say, Alice, about 105 years. What's the most amazing thing that you've seen? And I'm thinking, MTV, and and she goes, honey, she got real close. I don't want to creep you out, but she said, when I was a little girl, my parents read me a newspaper article about Orville and Wilbur Wright. And so I'm going, okay, carry the one, and okay, he takes me out. You were like 7 years old when there was the first airplane ride. And so I imagine her being one of the first people on the planet that would, run around her yard pretending to be an airplane. I share that because what we're trying, again, to do is create a sense of community, and we can't do that if we follow this linear algorithmic model. okay? How many people have been to Amsterdam? I don't need to know why. Okay? That's our stopping point on the way to Tanzania, okay? How many people have been to the Rembrandt Museum in Amsterdam? Okay. So Rembrandt, Dutch painter of the Renaissance, he's a master. One of the forms was chiaroscuro. It's light out of darkness. If you look at Rembrandt's paintings, if you look at his self-portrait, it's very dark, and I don't mean scary, but it's just a lot of dark tones, and what pops out are prominent features of his face. It's consistent through most of his work, most of the Renaissance. And there's tremendous value in that. The palette, color, the brushstrokes are amazing. But to me, it's always been very static, whether I see that in October or June, sunny, rainy, morning, night, it's Rembrandt. Now, who's been to the Museum of Modern Art in New York City? Who's familiar with Jackson Pollock? Jackson Pollock is kind of all over, right? So again, October, June, morning, night, sunny, rainy, 3 or 4 times in the same visit. When I stand in front of a Jackson Pollock, it is a different picture. And I offer it's because it's predicated on who I am, the experiences I've brought to that moment. That's the algorithm of life. Medicine is too Rembrandtian, static, linear algorithm. If A, then B, then C, then D, my job is done here. Why do I see parents saying, okay, Johnny, just keep walking? Because this scares people. This doesn't make sense. We have to give ourselves into the ambiguity and the uncertainty of, this is a reflection of me at some level. That's scary. That's the uncertainty, the unknown portion of life. But when you stand there and you say, okay, yeah, when you allow that to absorb you and to absorb it, then you actually have the most control over the uncertainty and ambiguity of life. We need more Jackson Pollock in our lives.
Embrace the change.
Embrace the ambiguity.
Is there change in medical schools in terms of their curriculum?
So the question was, is there change in medical schools with respect to curriculum? So it's a very interesting question. No, not at this point. You know, when I trained, I had 45 minutes of end-of-life care, but it certainly was not this conversation. And very few schools ascribe to this type of conversation. So I think the opportunity is when people have a voice and are sitting at that collective table to really question what has come before. Medical education is predicated on what comes out of Harvard and Yale, and the rest of the country just adopts that, right, wrong, or indifferently. You know, there's nuanced changes and versions of those models, but that's really what it is and has been. And so as practitioners, you know, we need to stand up and say, whoa, where are we going? And connect the dots to clinical practice, how we care or don't care for people, and economics. You can connect that loop and then affect some change. Sir?
Are there many palliative care physicians in Memphis? Do you know?
Palliative care physicians in Memphis, I'm going to defer to my new friends and experts here. I don't know, because I'm from Des Moines, Iowa. 10 or 12. Nationally, it is a tremendous shortage. I think tonight, I hope you've learned it's a tremendous shortage of physicians who even understand the journey of life, I mean, as a biologic organism. But they're very, very represented as far as physicians who are actually providing care in this country. And not just physicians, nurses, nurse practitioners, DOs, PAs, the real paucity of us goofy docs. Sir?
I'm looking for a point of entry for the patient on a micro basis as to how to achieve in a particular patient setting what you obviously seek to achieve. When we all have family physicians, at least I think most of us do, yet at the point of greatest need, that family's physician likely can't see us in the hospital because we're shunted to a hospitalist. Nothing against hospitalists.
No, it's a great
But
point.
they haven't known me since I was 30 or
Mhm.
25 or what have you. They are starting off with no family history, medical history, or even a happy thought. We're just a patient. So having the conversation that you say we need to have, and we do. I agree with everything you've said. And I say that from someone who's experienced it 4 or 5 times, and as a professional who does estate planning, I've addressed it. But if the system is not conducive to allowing the conversation that you said you need to have, how should we as patients make sure we have that conversation?
That's a great question. I encourage everyone, obviously, to advocate for themselves. Okay? And what you're going to run into is if you say, look, I want a palliative care consult, or I want the truth, or, however that's spun. So forget the title of this. It is really almost getting on a soapbox and demanding the truth. Okay? Because at the end of the day, we as a collective are not good at telling the truth. And you need to go bleep, 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 bleep. I don't buy that. I've seen Dad go like this over the last 6 months. What does that really mean? Don't tell me this is what we're going to do. Talk to me about what you're seeing and what you know. Talk to me about your experience. And you're going to have a lot of resistance. Because a lot of physicians, it's just, I'm the paternalistic, egocentric, what I say goes. So you have to, right, wrong, or indifferent, all right? Hopefully this is going to change. But we're at a juncture where you have to stand there and say, no, tell me what's going on. I had a friend whose mom was diagnosed a year ago, July, with stage 4 lung cancer. And she was livid in October when she said, you never told me she was going to die. She's a very intelligent woman, both the patient and the daughter. And so people feel abandoned, they feel cheated, they feel very disgruntled that you weren't truthful with me. In this sacred time when you're ill and you want someone to come clean with the truth, good, bad, or indifferent, put it out there on the table. When somebody doesn't do that, it stings even more. So for ourselves, for our loved ones, you have to demand. And don't worry about hurting people's feelings, okay? Because at the end of the day, it's your life. It's mom's life, period. And if that physician isn't going to come clean, find another one. And if that one's not going to come clean, find another one. Again, when I went with my mom years ago as this journey started, I didn't come in as, hi, I'm Dr. Ihrig, and I just say, hey, I'm Tim, the son. But I would want them to tell me, as best as I could, my role is to be son, and I know what's going on. But to say, look, I'm your customer. I want to define us as customers, but bottom line is, yeah, you are. You wouldn't accept that kind of service if you went out to dinner. But what?
Again, I agree with you.
Sure.
But the system, starting with the hospitalist and the economic incentives for the entire healthcare system to make money off of it, works against it. And the biggest stress I think patients have is they're worried about aggravating or offending their physician.
I say get over it.
Well, and yeah, if you do, it is very difficult to find another physician, particularly, for example, if you're on Medicare.
I agree.
Many doctors don't take Medicare. And if you hack off the guy you rely upon, where are you going to wind up? It's just not as easy.
It's not easy, but I'll encourage you with this, okay? Physicians deep down want to come clean. Really do. And all my friends, and this goes over the last 15 years, is I've encouraged them to have that conversation. 99% of those doctors, whether it's a hospitalist or specialist, says okay, and takes the time to kind of spill the beans. Say, this is what I'm thinking. And if you say, what would you do if it was your mom? Okay, hold them to task. And it's not conflictual to the point where they say, go find another doctor. All right, I've had that happen a couple times, sure. But it takes it to a different level of the relationship. When you demand the truth, and I offer that most physicians want to share that. They don't know how, okay? And so it's all right to say, look, is mom dying? 3 years life expectancy? Is that, you're kidding me. She was walking last week and now she can't even swallow. What is this gonna do for her? You say, well, it may give her 3 more months, but at what cost? So we need to be empowered as consumers. And yes, you run the risk of alienating that physician, but what's the ultimate cost? There will always be someone else who will care for you. If not, give me a call. My cell phone is in the bathroom, or cell phone number is in the bathroom. Yeah.
Any patient in Memphis in the hospital can request a palliative care.
Oh, really?
So I said any patient in Memphis can request a palliative care consult, which is light years forward from a couple years ago where patients would say, hey, I think, what's this palliative care service? I'm not ordering that for you.
Yeah, right.
Well, again, it's your right. So I recognize, and I'm not downplaying the situation that can and does occur, you know, with physicians and other care providers. I think we need to collectively stand our ground, and that's what's going to affect change. You know, it's sitting in the front of the bus. Yes.
Can you clarify what population sort of qualifies for palliative care? Is it people with cancer, people with life-threatening illnesses, or are you thinking of it in a broader way, like all of our, I mean, ideally, all of our care would be palliative, but I have a feeling it's much more
Great question.
narrow than that.
So I think there's a palliative component that should be interwoven into every aspect of care, all right? But true palliative medicine is for individuals of any age, like I said, neonates to 105, who have a potentially life-limiting illness, okay? And so that's the entry point. And like our family friend who is doing well, we walked that journey with her, and now we're out of the picture. 90+% of the patients that I'm involved with are coming to those last chapters of their life. And so that's the population. If I get pneumonia, it's not a palliative care referral, okay? If I get diagnosed with cancer, yeah, short of, you know, a basal cell carcinoma on my face, it can be excised and just do it at home with my razor, you know, absolutely. And the duration and intensity of that are absolutely unique for that person's journey. This is not a one-size-fits-all. And that goes back to being Jackson Pollocky, right? If I want to start a cardiology clinic, I've got the blueprint. I know what, I know how. I can do it here in Memphis, I can do it in Des Moines, I can do it in New York. Palliative medicine is different. Your needs are different than yours, than his. So we have to be comfortable with that ebb and flow of the journey as well. You had a question?
If you're not in the hospital, I mean, if you, are you listed in the yellow pages with like a PhD, a PAL or something, or how does one know?
How does one get in touch with a palliative care service? So each city is unique. Again, there's no standardization, and we're really in our infancy as far as, you know, what works and what doesn't, okay? There are very few again, true palliative medicine services anywhere, hospital, non-hospital, anywhere in the country, most programs are in a hospital, okay? There are organizations that have the shingle of palliative care or have some sort of non-hospital service, and I would offer your best resource would be to call a palliative team that's affiliated with a hospital and say, what are the resources available? And do a Google search.
Good old Google.
Yeah. So,
I was under the impression there was a palliative care unit at the Baptist. Is there not?
It just,
To me, when I look
hospital-based, yes, there is. But the question is, do they go once you're discharged? And I can't speak to that.
often at Crossroads, it has a component of palliative care within their hospice program. No,
It's-
it's not within,
It's in addition to, there's organizations like Crossroads, and so full disclosure, I just took a position as their chief medical officer, but there's not a pitch for them, but there's organizations that are saying, hey, we need to do something that is across a continuum and bring that opportunity to everybody, and so that it's seamless. Anything else? Questions?
You mentioned that there's some work that needs to be done in Washington with regard to our representatives. Some of us may not have any medical connections or not having the palliative care. We appreciate that. So how would we find out those people that are on both sides of the aisle that are open to hearing those important issues?
Sorry, but we didn't hear the question.
So she said she really likes your glasses, okay? And yeah, the question was, those of us who aren't facing an immediate medical need, how do we find and gravitate and share our concerns with those constituents inside the Beltway that kind of get it and are working for real change? So that's a great question, because there's some of them I don't even know, all right? I think it starts at your local level. It starts here, you know. What you're doing here in this very facility is facilitating that conversation. We all have opportunities to call local council representatives, our state representatives, and say, "These are my thoughts. This is my my hope and my desire." That kind of grassroots effort. You know, I'm meeting with the governor of Missouri in a couple weeks. I don't know this gentleman. He doesn't know me, but there was a groundswell of people saying, you know, storming the Bastille. And he said, okay, what's the organization in town that's doing this? Let's sit down and talk about them. And so when we bring together what we want as human beings, and then you say, look, you're struggling with your Medicaid population, and it's bankrupting the state, here's that intersection, and let's talk about opportunities, not from a, this is my business, but how do we care for people differently and shift that perspective. So start local, and always write to your national level representatives as well. And an interesting thing, I wrote a piece for Geriatric Today a couple years ago. In Iowa, in an election year, we have the unique opportunity to see every candidate 18 months before the actual election. So it's not uncommon to walk in and get a cup of coffee at the local shop, and there's a CNN regular. And so what I heard was the things that are threatening this country and the things everybody talked about were ISIS, gay marriage. Somebody brought up puppy mills in Iowa. I don't think that's threatening the United States. Okay, but everything but this topic. So we need to be the voice. We need to be educated. Everything to my limited knowledge that has affected great social changes started with a grassroots effort. So. I do have a website, yes. You could just Google my last name, Ihrig, I-H-R-I-G, and find out some more information. And I say this sincerely, okay, to every organization and every group I've ever spoken to. You can track me down, and if you have questions about all the stuff we've talked about, if you have personal questions, I do consults all over the world. Talked to a guy last week whose grandmother is in Italy and dying of gallbladder cancer, and he's a student in New York. And we piped in his parents who are living in Germany. And so, again, it's not unique to, I mean, this is a human experience. If you have questions, reach out. I'll do my best to answer or guide you in a direction that can support you. I just don't do windows, okay? Anyone else? Yes?
I consider myself kind of educated in this area. And had really no idea that palliative care was different than comfort care. And it actually is.
Very much so.
And
It includes comfort. They're not
right.
juxtaposed.
So that's something that I'm not sure even physicians who practice, who believe that they are able to provide palliative care, I'm not even sure that they know that it's more than just.
That's a great point, and you're right. Again, one of the things Dr. Diane Meyer and I and the CAPC group is trying to do this year is really define it. To take away some of that ambiguity. If you want to call yourself a palliative care clinic or prescriber, this is what it is. This is the standard you have to attain, period. So yeah, and again, I think it's a growth issue. We've only been around as a specialty and talking about this for a couple of years. So I look at it as an opportunity rather than to be dissuaded from continuing the conversation. So.
Is it just the United States that's struggling with trying to figure out palliative care, or have any other countries figured it out and we can learn from them?
Great question. Is it just the United States that's struggling with what this is, or other countries? It's much more prevalent in many other countries. Our neighbors to the North, Canada, Western Europe, Great Britain, they still struggle with it as a mechanism of, what we're really talking about is population health. How do you care for the sickest of the sick? It's not ubiquitous in these other countries, but they have greater familiarity with the word and they're not afraid of it. And what's really interesting is I've had colleagues from the UK, some from Brazil. I had a friend of the health minister of the Israeli health minister reach out and said, we recognize the global economic importance of changing your system. How did you do what you did? Can you help us do that so we can collectively come back to the leaders of the United States and say, here's what works, you got to do it now. So there's a acute recognition from other countries of what's going on, much more so than our own legislators. So, I thank all of you. Have a beautiful night, and thank you for your attention.